Okay, I think we'll go ahead and get started. Welcome, everyone. Thank you for attending today's webinar on the COVID-19 Rapid Response Research supported by the University of Virginia Global Infectious Diseases Institute. I'm Allison Chris, Director of the Institute. Today, we'll hear from 8 research teams at UVA we are supporting who are taking exciting interdisciplinary approaches to address pressing challenges related to the COVID-19 pandemic. These researchers are supported by Institute collaborative seed grants, as well as a rapid response fund that is earmarked for studies related to the pandemic. We will be recording this webinar and it will be available on our website. As a bit of history, the Global Infectious Diseases Institute was established in 2017 with funding from the offices of the Vice President for Research and the Executive Vice President and Provost. Our premise is that the study of global infectious diseases is intrinsically interdisciplinary, and the projects that will be presented today highlight how researchers with diverse areas of expertise can come together to achieve something that no one individual can. Our mission is to nucleate and support collaborative transdisciplinary research on infectious threats of global impact. You can learn more about the Institute and our efforts on our website at giddy.virginia.edu. Before our first presentation, I would like to thank the Vice President for Research, Malur Ramasubramanian, and VPR Chief of Staff, Cheryl Wagner, for their contributions to the Rapid Response Call. I would also like to thank Linda Columbus, the Executive Associate Director of the Global Infectious Diseases Institute, as well as the Associate Directors Roseanne Ford, Bob Nakamoto, David LeBlanc, and Jason Pappin for their contributions throughout this process. Finally, I'd like to give a big thank you to Carrie McGowan, the Penn University Institute Coordinator, and Mike Davis, Institute Program Manager, for their hard work in organizing today's event. So we will begin with Dr. Shanmuga Khani from Dr. Martin Wu's lab from the College of Arts and Sciences, who will present their project PCR Dipstick as a point-of-care diagnostic test for COVID-19.
Hello, good afternoon to everyone. First, I would like to thank GIDI for selecting our project for the COVID-19 Rapid Response Grant. We propose to develop a PCR dipstick as a point-of-care screening and diagnostic system for COVID-19. So, next slide, please. Thank you. So, COVID-19 has become a serious health threat all over the world. At this moment, there are no appropriate treatment regimens or vaccines available for COVID-19. So preventing the spreading of this disease is the best way to brought this situation under control. To brought the situation under control, the early and efficient detection of COVID-19 is very crucial. Currently, there are 2 types of tests are being used for the detection of COVID-19. One is the antibody test and the other one is the nucleic acid test. In the antibody test, the antibodies that are generated for the coronavirus in the infected patients were being detected for the detection of COVID-19. In the nucleic acid test, the specific target genes are detected to detect the presence of the disease in the patients. In the antibody test, it took just 20 minutes to 2 hours. However, the nucleic acid test take 4 hours to 1 day. One more thing about the antibody test is that it cannot detect the early stage infection where no antibodies are generated during the early stage of infection stage. However, the nucleic acid test can detect the early stage infection also. One more drawback with the antibody test is that only blood can be used for as a specimen to detect COVID-19. However, the nucleic acid test can be used to detect the presence of pathogen in any of the specimens like nasal swab or stool or saliva. So comparing these 2 tests, each of them have certain limitations in different facets. So a good test that can overcome all these limitations will be very efficient for controlling this COVID-19. Therefore, we attempt to develop the PCR dipstick for the COVID-19. The beauty of this PCR dipstick is that it is a molecular test and it is very rapid compared to the other available molecular test. It can detect in a short duration of less than 2 hours, and it is very cheap, which is $5 per test if it is produced in a massive amount. However, the currently available tests are very expensive and requires the expensive equipments also. And this PCR dipstick is very simple easy to perform, as simple like a pregnancy test. Here the results can be visually interpreted with the naked eye. So no expertise or any special equipments are required to interpret the results. So any layman healthcare worker can perform the test and reveal the results easily. As it can detect the infection at the early stage, it is very crucial to prevent the spreading of the infected patients along with the community. And this PCR dipstick requires only a thermal cycler, which can be easily deployed at any small scale healthcare centers very easily. However, the currently available tests, they require a huge RT-PCR machines, and they also requires the expensive reagents, and it also requires the personnel to be very expertise in performing the test, and also he need to interpret the results in a proper way. So however this test is visually interpretable, it can be very easy for the healthcare workers to perform this test. Considering all these advantages, it is very easy to implement this at the point of care. I have experience on developing this PCR dipstick for the detection of antimicrobial resistant pathogens from stool samples, and it has been already developed into a diagnostic kit in the market. So I believe that this PCR dipstick can also be successfully developed into the commercial market for the detection of COVID-19, which will help the healthcare workers to efficiently fight against the COVID-19 to reopen the society as before. So we believe that our project will give a new way to the COVID-19 detection. Thank you.
Thank you very much. That is very exciting. If we could have this, I think it would really revolutionize our understanding of when we can go back to work and reopen. Thank you. So our next speaker is Bethany Teachman from the College of Arts and Sciences. She'll be working with Laura Barnes from the School of Engineering and Applied Sciences on their project, Online Intervention to Reduce COVID-19 Anxiety and Predict Mental Health Trajectories Over Time.
Thank you for the opportunity to share a little bit about our work. So our project grows from the desperate need to bring mental health care to people during this challenging time. So anxiety disorders are very common. So in the general population, approximately 1 in 4 people will develop an anxiety disorder at some point in their lifetime. And we can expect especially high rates of anxiety during this pandemic. So a recent survey that just came out suggested that at least 70% of people reported very high levels of stress tied to COVID-19. And there's a number of reasons to expect that managing mental health during this time will be a major challenge. It is a novel stressor. It is uncontrollable in certain ways, and it has enormous health, social, and economic consequences for people. So we can expect that there's going to be a real need to bring services to people. The tricky part is how, because at the same time as anxiety is going to be very common right now, people have less access to care, partly as a virtue of the need to do physical distancing and all of the other reasons that it's hard for people to access mental health care, and that's especially problematic right now. So our team launched Mind Trails. It is an online program to reduce anxious thinking. And it's based on extensive research showing that individuals who are vulnerable to anxiety tend to interpret situations in really negative ways. They tend to sort of see things in a catastrophic way and kind of assume the worst in situations. And so what Mind Trails does is it tries to shift those negative interpretation biases by giving people lots and lots of practice of thinking about potentially threatening situations in new ways. And from our earlier studies, we have some promising results from earlier lab and online studies, but also lots of critical open questions about how to strengthen the effects and how well does it fit for the current crisis. So to what extent is it a good fit for individuals who are struggling with anxiety tied to the current pandemic? So what we've done is made some adaptations to the program to fit COVID-19 and to really get a better assessment of how individuals are struggling tied to COVID-19. And our plan is to enroll 500 participants who are high in anxiety. We're going to offer them 5 weeks of free training to try to shift their anxious thinking patterns. And the second part is to look at, can we track these individuals for a period of 6 months after the end of training so that we can determine who shows a sort of resilient pattern of having lower anxiety and functioning well, and who ends up struggling more and has worsening symptoms over time. So we want to look at what is it about the coping behaviors people are doing now, the ways that they're trying to manage the challenges now that are going to predict their long-term course in terms of their mental health adjustment. And this work, I think, is important for two reasons. The first is the obvious, that we need to offer help to people now who are struggling with significant anxiety as a result of the current crisis. And we need to do it in a way that doesn't require people to come to us, but thinks about how we can bring services to people directly. And the second is that we really need to understand who is likely to be struggling in the long term, so that we can get these people extra help and also move towards prevention approaches by really identifying what are these earliest markers of risk for long-term problems. So I want to thank the Global Infectious Diseases Institute for their rapid response grant support and the chance to look into these questions. And we'll be excited to come back and let you know what we find.
Thank you so much. I think we all need this, and I really appreciate that you have taken this platform and now you can mobilize it to combat this pandemic. Thank you so much.
Thank you.
All right, our next speaker, we will now hear from Henning Mortveit from the Biocomplexity Institute and Initiative and School of Engineering and Applied Science, and Peter Belling from the School of Engineering and Applied Science, who will discuss their project, Machine Learning Efficient Behavioral Interventions for Novel Epidemics.
Hello, and thank you for this opportunity to talk about our work, and also thank you for the support. So I'll present some of the background for the work and then hand over the microphone to my good colleague, Peter Belling, in the middle of this. So if you go to the next slide, please, then so this is about how to assess what people do during epidemics and what drives their behavior. So to provide some background, my group at the Biocomplexity Institute have looked at epidemics for a long time, almost 2 decades now. And one of the things that we do, a large part of what we do, is to assist government agencies in assessing interventions and vaccination resource strategies. So we will use modeling and large-scale computations to basically carefully assess what kind of interventions are effective, how should you do it, if you have limited vaccines, how do you go about to distribute them, and so on. And now it is also becoming very clear that the human behavioral component is very important in how epidemics unfold. So you see it now. People may look at news, and it may impact them in some ways. Whether people choose to comply with a stay-home order may tie into a financial economic situation. Maybe they can't afford to. So in our work at the Biocomplexity Institute, we have models that incorporate all these features, but we also need to carefully capture and incorporate the human behavioral modeling. We need to represent it accurately, and we need to see really what drives people's choices. So that is why we teamed with Peter Belling and Stephen Adams at ESE to then combine our models with the learning methods that they have developed that we will be extending through this work. So Peter, over to you.
Okay, great. Thank you, Henning. Yeah, Henning's group uses a lot of different kinds of models, but one of the principal tools they have for helping policymakers think about things like pandemics is something called an agent-based model or agent-based simulation, where there are lots of interacting computer agents, if you will. And what you can then do with the model is study the kind of aggregate behavior and the emergent behavior as things unfold over time. So then the question is, how do you build something like an agent-based model? And if it involved, say, people moving around, walking from one place to another, how would you choose the route that they walk? And it turns out that that's kind of a tough topic, because you could choose the routes based off of minimizing the travel distance, right? That'd be a reasonable kind of thing to engineer into your computer agent. But, as we all know, we make choices that are dependent on a lot of additional complexity. Like, I like to see the sights a little bit. I like to be kind of choose paths that are not as crowded as others. And of course, that would be influenced by something like the notion of social distancing. So there's a context to our decision making that's very important. And so the question is, how can we engineer that kind of thinking into these models? And the approach that we're taking is to think about the decision making by the agents in the model in terms of something called reinforcement learning, a basic paradigm where agents take an action and then receive some kind of reward from the environment. Could be a positive or negative reward. And then what they're doing then is choosing their actions to maximize the return that they get. Now that kind of model, as simple as it sounds, is actually has some utility in psychology and in the modeling of human behavior and animal learning and things like that. And it also has a kind of rich supporting mathematical structure and set of algorithms that allow reinforcement learning to be studied in the context of things called Markov decision processes and algorithms that can be used to do incredible things like learn chess in 3 hours. So there's a rich kind of computational support for this kind of structure that we're thinking about. And what we want to do is use that computational structure in reverse, as it were. So we're going to look at populations and see what kind of things they're actually doing by observing the actions that they take in a given state. And then from that, make an inference about what is the driving reward that they're trying to maximize. So what is the utility that, if you will, in economic terms, or personal utility in more personal terms that the people are trying to maximize. So we're sort of making inferences about what's driving their behavior. So that's the technical underpinnings of what we're doing. And the goal, again, is to take that and use it as the basis for constructing higher fidelity agent-based models that would then allow Henning and his group to explore different kinds of scenarios that could be useful for thinking about new kinds of policies. What if we ask people to wear masks? What if we were to change social distancing rules from 6 feet to 12 feet? What might be the impacts on behavior, and what might be, most importantly, the aggregate outcomes of all this? So thank you.
Thank you both for the presentation. I think from some of what we viewed on the news over this past weekend, it's pretty clear that there are people are taking into their own hands how they are doing their own social distancing or not. And so I think that being able to incorporate that into a model and predict outcomes based on these kinds of activities would be really, really useful. Thank you. Okay, we now turn to we now turn to Dr. Jundong Lee, who has dual appointments in the School of Engineering and Applied Science and the School of Data Science, and Daniel Meacham from the School of Data Science, who will jointly present their project, Quantifying the Impact of Data Sharing on Outbreak Dynamics.
Okay, thank you. We will start with Daniel. Next slide, please. So actually, our project is doing something very similar to what was just presented. We are just coming from a different background, and we're zooming in on different aspects of the modeling. So some background: humanity has a long history of sharing in disaster contexts, but usually what we've shared are more or less physical goods and services. And over the last few decades and the accompanying outbreaks, the role of data in decision-making has become more important. And so our question is, what is the way in which data sharing can actually enhance or inhibit positive outcomes in terms of outbreak management? And in order to do that, we will build models, and hopefully we can actually collaborate with some of the others here who are doing such modelings. And in those models, we will model the relationship between decisions and the availability or quality of data or metadata or other representations of the data. And then we want to basically run these models under different conditions in order to tease out the salient parameters that contribute to the role of data in the outbreak and how we can then leverage that for decision-making in ongoing outbreaks. And in order to do that, we will not only look at the current outbreak, but we will also go back to other outbreaks in order to see what we can learn from that. And with that, I hand it over to Jundong.
Hi, this is Jundong. So next, I will talk about the broader impact of this project. So if successful, that we hope that this project will help us identify the parameter sets under which the specific modes of sharing or withholding information have the largest effects on outbreak dynamics. And this research is also expected to yield best practice recommendations in terms of the sharing of data and metadata in the context of specific outbreak-related decisions by stakeholders, ranging from individuals to groups to institutions to the governments. And next, I will also briefly talk about our specific research plans. And there are several different steps. So in the first step that we will model data flows through an outbreak decision network. So here that we want to model the interactions among different stakeholders as a heterogeneous decision network, where the nodes denote different stakeholders and edges denote different types of interactions among them. While the interactions can be categorized based on the availability and sharing of data pertaining to that particular type of interactions. And we refer this kind of data sharing or metadata as data flow, so which can be modulated in several ways as one kind of interaction will trigger the next. And in the second step that we want to quantify the impact of data sharing on outbreak dynamics. So here that we want to study the causal relations between individual or aggregated decisions, the associated data flows, and the spread of the pathogen and the disease. So such decision-making process are often based on randomized control experiments. However, that they could be quite expensive in terms of both time and financial resources, which makes them very challenging to perform in the outbreak context. So one natural way to solve this problem is that we will directly look at the observational data of different stakeholders, trying to infer the causal effects between a specific decision, such as the closure of the school and an important outcome, such as the spread of the disease. And in the third step that we will leverage our obtained insights for the current and future outbreak management. So specifically that for a given outbreak management context, that we can fine-tune the model parameters for that context in order to use the model to address questions that may arise in the near future. And the last but not least, that we also would like to share our research progress early, openly, and often to help the decision makers to take better actions to alleviate the adverse impacts of the disease outbreak to individuals as well as a society. And we will make our data and our research findings publicly in the GitHub repository. Yeah, thank you.
Thank you both very much. Not only is the research question fascinating, I really appreciate your openness and also your willingness to collaborate with others. And one of the things the Global Infectious Diseases Institute tries to do is bring together teams of researchers from diverse areas to come together to create even better, better research from it. So your model building and all the people doing model building in this area, we'd love to bring you together to have more conversation. Thank you very much. Okay, we now turn to Preston Reynolds from the UVA School of Medicine, who is also a member of the Health Equity and Access in a Rural Region Steering Committee, and she will talk about their project COVID-19 Impacts on Rural Populations. She will work with the co-principal investigator Peggy Scott from the School of Medicine and Frank Dukes from the School of Architecture.
Thank you, Allison. I have to say that this HERE Steering Committee is incredibly grateful for the grant provided from the Global Infectious Disease Institute. HERE is an acronym for Health Equity and Access in Rural Regions. It's a community-based group that promotes access to medical care and infrastructure as a means to achieve health equity for some 15,000 residents in the area connecting southern Albemarle, Buckingham, Fluvanna, and Nelson counties. HERE was established over 2 years ago under the leadership of Mayor Nancy Gill. Peggy Scott, who's a co-PI of this project, is co-chair of the HERE Steering Committee. We've completed a regional health assessment, created a website, hosted several local health events, and launched a clean water initiative. This really important grant will enable the HERE Steering Committee to plan next steps in addressing the health needs of the region and collaborate with the health department and other regional partners, including the University of Virginia. We all have a lot to learn how rural communities are coping with the COVID-19 pandemic and resulting restrictions of stay-at-home orders announced by the governor on March 30th, 2020. We intend to gather quantitative and qualitative data through the administration of a survey. Our hypotheses are listed here: that geographic distribution of rural populations slows disease transmission and reduces the risk of contracting COVID-19. Geographic separation of individuals in rural populations means that these populations do not need to alter their behavior as much as urban populations in order to achieve social distancing. And paradoxically, widespread social distancing policies stress an already fragile rural private and public sector infrastructure, such as internet, clean water, access to food and transportation to and from work. This grant will fund a community-based participatory research project that relies on participation of the HERE Steering Committee and community leaders who are residents in the area. These local residents will be compensated for their participation. We've identified 16 community residents who will administer our survey in collaboration with researchers at the University of Virginia. These local residents represent social groups, such as Boys and Girls Clubs, Black churches, businesses, farmers and vendors at the farmers market, JABA and the isolated elderly, parents involved in homeschooling, and parents involved in the PTA, as well as residents of geographic areas such as Esmont, Scottsville, Schuyler, and the more rural sections of Buckingham, Fluvanna, and Nelson counties. The survey consists of 40 questions. The questions look at behaviors after the announcement of stay-at-home orders. We are seeking to understand how residents actually learned about these restrictions and if their knowledge of someone who was sick with COVID-19 impacted their behavior. We also want to know if they feel safe, especially if others in the community fail to respect PPE and social distancing recommendations. A set of questions explores infrastructure and access to essential needs. Many residents in this region need to purchase water for drinking because their wells are not safe. And they rely on public transportation to get to and from work. So do they feel safe going to the store to get water and food? Did the reduction in public bus service impact people's ability to get to and from work? And thus, did it impact their finances? Do those that work at UVA, did they access the emergency funds that were available? Forced to stay at home has raised concerns among the HERE Steering Committee about the well-being of residents. So we're asking questions about unhealthy behaviors such as domestic violence, alcohol, drugs, and lack of exercise. Since much of this area lacks stable internet and cell phone coverage, we're also interested in how stay-at-home orders have impacted school-aged children and their progress academically. Most important, we want to connect residents with resources, so the survey will enable individuals to let us know if they need help and where to go to obtain the assistance they request. We hope these data will help us understand how to prioritize infrastructure initiatives, plan for future pandemics, and strengthen access to medical care and essentials of healthy living. Thank you again.
Preston, thank you very much. I really am impressed by the community that you've built in this rural area and the people you're bringing together. And I think it's clear that the rural areas like we live in pose challenges that need to be addressed in a different way than thinking about big cities. And so I'm glad that you're doing that. Okay, our next speaker will be Dr. Peter Caston from the UVA School of Medicine, who will now talk about his project with Bill Petrie from the School of Medicine, cross-protective immunity and vaccine design against SARS-CoV-2, previously known as nCoV-19, and now we call COVID-19.
Great, thank you. So as I think we're all aware, the near-term control of COVID-19 depends critically on social interventions and test, trace, isolate strategies, as well as new therapeutic strategies to mitigate severe effects of the disease. However, our best long-term option for control is a safe, effective, and accessible vaccine. As also we're painfully aware, the process of developing a safe vaccine, even at breakneck speed, is a lot slower than we'd like. In the past week, there have come out initial data from some of the first generation vaccines, both the ability of those vaccines to elicit antibodies in first human test subjects, and also the ability of some of those vaccines to protect non-human primates against challenge with the SARS-CoV-2 virus. One of the striking things about these first results is some good news and some bad news. That in these initial results, the non-human primates were largely protected against clinical disease in this particular vaccine and challenge model. However, when exposed to the infectious virus, the virus was able to replicate both in their nose and in their lungs. And so if this test is indeed predictive of what we get with the first vaccines moving very quickly forward into trials, we may have a first generation set of vaccines that may provide some protection against clinical disease, but not entirely interrupt transmission. And so that would achieve some of the goals of a vaccine, but not all of the goals of a vaccine. It's still too early to tell whether that's precisely the case, but that's certainly the way the initial data are starting to point. We also know, however, that in a number of similar viruses, both MERS and also influenza, which has been extensively studied both as a respiratory virus and as a pandemic threat, that sterilizing immunity that indeed can prevent transmission may occur at mucosal surfaces, not just, we often look at antibodies in the blood, and vaccines are often given in a way to elicit blood antibodies, but antibodies at mucosal surfaces, not just snot, but in your lungs and other areas of the respiratory and GI tract, may be critical for sterilizing immunity. And so we've taken the approach of trying to design a vaccine explicitly to elicit antibodies at mucosal surfaces to try to prevent not only clinical disease, but also transmission of SARS-CoV-2. And my colleague and co-PI, Bill Petrie, has extensive experience in other pathogens that, non-viral pathogens that infect at mucosal surfaces, and developing vaccine candidates for those. I work on respiratory virus entry, and we have developed ways to assess how antibodies neutralize viruses and go through and take an antibody sample and really say, how is this working, and how can we then optimize vaccination strategy. And so we're putting these two together to come up with an iterative strategy for testing out vaccine platforms, analyzing the antibodies, and improving as necessary. And so this grant has enabled us to spring into action quickly. We already have some first candidate animal vaccination attempts so that we can analyze the antibodies quickly And it's also let us start expanding the circle of collaboration, both at UVA, also Barb Mann, who is, I believe, on this webinar, and beyond nationally and internationally, to bring together a team to try to develop a second generation vaccine that may have some improved properties. So thank you, we're grateful for the support.
Thank you, Peter. It's really exciting to hear about your progress already, and I'm looking forward to hearing more about how things go in the coming days and weeks. Thank you. Up next, we have Rupa Valdes, who holds appointments in the School of Engineering and Applied Science and the School of Medicine. She will describe her project impacts of COVID-19 pandemic on individuals with chronic health conditions.
Thank you. It's been wonderful to hear about the range of projects that are being initiated. So our research builds on our previous work at the intersection of public health, systems engineering, and cultural anthropology to understand the lives of people living with chronic health conditions and to design interventions to support them and their families in the home and community. So it's been widely reported that individuals living with chronic health conditions are particularly at risk, not only for experiencing complications from COVID-19, but also that they are at risk for experiencing more dramatic negative health-related, economic, and social impacts from the wider policy and societal changes that are being implemented. So these individuals often rely on ongoing interactions with the healthcare system, for example, for treatment or for disease monitoring, as well as rely heavily on social networks. And this could be for support related to logistical arrangements and for emotional support. They also rely on public goods and services, such as appropriate medications and diets, to maintain their quality of life. So during this pandemic, when policies have been put into place limiting access to options such as elective surgeries and outpatient treatments, in addition to policies that strictly enforce social distancing, these individuals are particularly likely to experience negative health outcomes that are associated with interruptions, both in the formal healthcare setting, but also what we would call informal care. So that is care that's provided by family and friends that they may no longer be able to interact with. Additionally, these people have often made significant financial investments in their treatment. And so, for example, one example you can give is if somebody has been on an ongoing course, for example, of physical therapy or immunotherapy, what we would call allergy shots, and they are not able to access that care for several months, they may have to go back in treatment, which would result in additional copays, in addition to lower quality of life for that period of time. So the pandemic, although there are likely to be all of these negative consequences for individuals with chronic health conditions, there may also be some widespread changes that could prove beneficial for certain aspects of chronic disease management. So, for example, the widespread adoption of telemedicine is one example. So when people do not require an in-person manipulation or treatment, telemedicine may facilitate more access in settings where someone, for example, has limited mobility. So our in-depth qualitative study is going to be facilitated by multiple social media platforms, and we're seeking to understand two things. So first is, what are the social, economic, and health-related impacts of COVID-19 on individuals living with a wide range of chronic health conditions? And then to follow up from that, what changes can we implement at multiple systems level to mitigate the negative impacts and sustain positive ones over time? We'll be focusing on 5 different chronic health conditions that have shown early evidence of having impacted people in different ways during the pandemic. So some examples of these could include medication access, limited support from others in the community, or delayed treatment. And we're going to draw upon existing conversations on these social media platforms, as well as use these platforms as a way to engage people in surveys and interviews to dig deeper into some of the questions that arise from looking at the existing conversations. And our hope is that this early and in-depth understanding of the negative impacts of the pandemic on people with chronic health conditions will, again, give us some insight into what interventions could look like, both at the level of individual behavioral change, but also at the level of relationships and the community and policy changes more broadly. as ways to mitigate both the short and long-term unintended consequences of the changes that are taking place. And then on the flip side, again, learning about some of the adaptations and interventions that may have been adopted in an ad hoc way in different communities, how we can get a sense of what those are, how they may have improved quality of life for people in those particular communities living with chronic health conditions, and how they may be facilitated and enhanced so that they can be adopted more widely both during the pandemic and afterwards.
Thank you so much, Rupa. I think it's a really important topic. There's so many in our community who are affected by this. And one of the things that's really struck me with what's happened over the last few months is thinking about the ways in which our, the ability to use the internet, for instance, this webinar today on Zoom has really changed the way in which we interact with each other, and our adaptation to that as well, besides our own community efforts in person as best we can with social distancing and such. So thank you very much for your presentation. So our final presentation this afternoon is from a team of pulmonary and critical care physicians from the School of Medicine. And I'm sure they're very busy right now, so thank you for taking time to participate. And we want to really thank you for your care and service to our community at this time. And so today we're going to hear from Kathy Bonham, who will discuss the project, The Host Immune Response to Severe Acute Respiratory Syndrome, SARS-CoV-2, aka COVID-19, which she will complete with Drs. Alex Cattle and Lindsay Somerville.
Thank you, everyone, and we're so grateful for this grant. As frontline providers in the ICU, we've observed sort of an unprecedented illness, having an ICU of all the same type of acute illness, but even within that, our patients are unique. And it strikes us that our patients that are coming with frailty and old age from nursing homes can sometimes do very well. Our patients that are young and have no previous health conditions can sometimes do very, very poorly. And so our objective is to really understand why certain patients develop respiratory failures and others do not, and particularly the at-risk populations. Our objective is such that we think we can develop some better targeted therapies, or we can use some currently available therapies that have a more personalized approach. So to accomplish this, we've developed an ICU patient biorepository. And so this is really a credit to our patients and their families in the midst of their critical illness. They've agreed to donate blood and lung fluid, bronchoalveolar lavage for this study. And so the objective is to compare 4 groups. We have patients who have COVID-19 with and without respiratory failure. We also have patients who were stricken with influenza, and patients who have not had respiratory failure but have been an ICU admission for other reasons. Our overarching hypothesis is that there is a dysregulated immune response, and so we've kind of taken a 3-pronged approach based on our own experience and our own lab interests. Dr. Cadle will be comparing the evolving cytokine response. So there's some really interesting data from Wuhan. I'm sure many of the scientists in this group have read these papers too, where there is an elevated IL-6 in non-survivors, and there's also an association of case severity with elevated IL-1 inflammatory markers. And so this has led some to use already existing drugs like anakinra, tocilizumab in our patients. There's a lot of heterogeneity into the way that those drugs are being used right now. And so our objective is to look longitudinally with serial samples from our patients on the evolving IL-6, IL-1, and TNF response. And this is going to allow us to kind of map out the cytokine response in conjunction with the clinical factors that we see. We'll be performing RNA-seq and a confirmatory Luminex assay to do that. And so the results will really inform selection of targeted therapies. And it lets us look at delivering the right drug at the right time, which we think is actually quite important to avoiding complications and maximizing response to the drugs that already exist. My particular interest is in effector memory T-cell responses, and so I'll be taking that angle. Some previous data from our lab suggests that patients who have rhinovirus infection lack sufficient CCR5 effector memory Th1 responses. And so I'll be looking at serial samples and deconvoluting the identified cell populations to begin to look at that response. We'll validate that with cytometry, flow cytometry and matched PBMC samples. And finally, look at that also in the bronchoalveolar lavage samples. The final aim is being accomplished by Dr. Lindsay Somerville. She's had experience in looking at influenza A in vitro culture models. And so she's going to model lung infection using primary human alveolar macrophages, as well as alveolar epithelial cells. And she has a well-established cell line for these. We'll be exposing alveolar macrophages to heat inactivated SARS-CoV-2 in co-culture with the alveolar epithelial cells. And so together, these three aims will really kind of take a broad-based approach to being able to untangle the what's special about some of our patients and how we can perhaps take a more personalized approach to the SARS-CoV-2. And so we're really grateful for this grant, and we're looking forward to all the results we're going to see.
Thank you very much, Dr. Bonham. I completely believe you that it would be wonderful if we knew more about why some people are going to respond better than others when they're infected, and it would help to target the treatment and all the limited resources that we can have in our healthcare system to make sure we're prioritizing those patients who are at most risk. So thank you. Well, thank you everyone for attending today's webinar, and a special thank you to all of our presenters for taking the time to share with us today their exciting research plans. And we look forward to learning in the future about your impactful discoveries. There will be a recording of this webinar available on our website, giddy.virginia.edu, and you can also learn more there about our research goals and projects. So please stay safe, everyone, and have a good afternoon. Thank you.